Good afternoon, I think most places. This is a session at the ASSA meetings sponsored by or hosted by the Labor and Employment Relations Association. And the title of the session is Caregiving, Work, and Social Programs. There are 4 really interesting papers today and 2 discussants who will discuss them. We'll do the first 2 papers in the program listing and then have the discussion of those 2 papers, and then the final 2 papers and the discussion of those. With that, I should have introduced myself. I'm Joe Hotz from Duke University, and I'll chair the session. If you do have questions, please put them in the, submit them to the Q&A, and we will try to address those questions at the end. So we will wait till the end to do all questions. With that, I'd like to start. The first paper is the impact of childhood health shocks and parental labor supply, and Amandi Gaulke is going to do the first presentation.
Yeah, hi, I'm Stephanie Rennane. I think, should I go ahead and get started with my paper instead?
Yeah,
maybe it's a little bit out of order.
Yeah, we'll be a little out of the order. We'll shift Mandy to the 3rd slot.
Okay, all right. Sorry for the confusion, but I'll go ahead and share my screen. One moment, please. Okay, can everyone see my slides? Or my? Yes, great. Okay, so I'm Stephanie Rennane from the RAND Corporation. Today I'm going to be presenting my paper, The Supplemental Security Income Program and Caregiving Burden for Families of Children with Special Needs. This project is a collaboration with Lynn, Karoly, also at RAND. And I want to be sure to thank our funder, the National Institute on Minority Health and Health Disparities, for supporting this work. So this project is motivated by the well-known fact that caring for children with special needs is both mentally and financially costly. So children with special healthcare needs require a variety of health therapies and treatments, educational and social services. And each of these therapies often requires coordination between providers and insurance companies, and a series of complex decisions that the families and caregivers need to make. While some of these direct costs are often covered by health insurance, the additional care required to care for these children, as well as a lot of these coordination costs, often fall on the families themselves. And these challenges in coordinating and providing care have been shown to lead to increased stress, financial risk, and health consequences for families. And of course, disappointingly, although perhaps not surprisingly, these difficulties are highest for the most disadvantaged families who have less flexibility in their work schedules, less out-of-pocket kind of disposable income to cover extra costs, and less familiarity in navigating the care environment. So the Supplemental Security Income Program, or SSI, could mitigate a lot of these costs for families. So SSI provides cash assistance and access to Medicaid for low-income families of children with special needs. In 2020, the maximum monthly benefit was quite sizable at $783 a month. Because the program is means tested, of course, it provides benefits to low-income families. So children can participate in SSI if they have a qualifying disability, which can include a variety of physical impairments as well as mental impairments and developmental delays, so long as the disability is shown to last at least 12 months and impair a child's ability to function similarly to their peers. Disabled adults and elderly individuals with low incomes can also participate in SSI, but child participation is going to be the focus of our study here. And child participation in SSI has grown significantly in recent decades. In 2019, over 1 million children received SSI benefits, and total expenditures exceeded $10 billion. So a variety of work has examined how SSI affects some margins related to the caregiver burden that I highlighted earlier. So I've listed some of the findings from this body of research here. So as child participation in SSI in particular has been shown to increase household income, to reduce food insecurity, and to reduce parental labor supply on the intensive margin. Child SSI has also been shown to provide a predictable and steady income source for households who otherwise have a lot of volatility in their household income. And SSI provided to low birth weight infants has also been shown to improve infant development and parenting behaviors for those infants. But the effect of SSI on the kind of mental and financial cost on caregivers that I mentioned before remains difficult to quantify. And that is the focus of our study. We're aiming to fill that gap. So our two main research questions are, first, to what extent does SSI reduce caregiver burden for families of children with special needs? And we're also going to explore the disparity dimension here by examining to the extent to which it mitigates disparities, particularly for these low-income families and minority families of children with special needs. So to do this, we're going to analyze survey data that has a representative population of children with special health care needs. And we're going to develop an IV strategy and instrument for SSI participation using a measure of the net financial gain of participating SSI compared to participating in temporary assistance for needy families, or TANF. I'm going to spend the next few slides going into that approach in detail, but at a high level, what we're going to be doing is exploiting within state variation in the net financial gain due to variation in the size of TANF benefits across households within a state. So first, I just want to provide a little bit more background on the ways that SSI and TANF can serve as substitutes. So in 46 states, a single individual cannot receive benefits from both SSI and TANF, although different individuals in the same household can receive benefits from the two programs. So prior work has shown that both individual incentives and state incentives tend to shift the caseload from TANF to SSI, or TANF's predecessor, AFDC. So on the individual incentive side, this comes from the fact that the SSI benefit tends to be larger in most cases than the TANF benefit. So the papers I've listed here analyze growth in SSI participation for children during the 1990s. And for example, the Garrett and Gleed paper estimates that about 1/3 of the growth in participation during the 1990s was due to this caseload shifting from AFDC. The second main source of incentives, as I mentioned, is state incentives, and that's driven by the fact that SSI benefit is paid for by the federal government, while the TANF benefits are covered out of state budgets. So a variety of papers, some of which I've listed here, have looked at a variety of state parameters, whether measuring negative fiscal shocks in the state or other parameters related to welfare reform, and have also found that kind of where there's more incentive for the state to shift participants to SSI, you see that this is associated with higher participation in SSI. So most of this body of work relies on variation across states and over time to establish this conclusion about caseload shifting. What we're hoping to do in this paper is take this approach a step further and look at variation within the state. So as I mentioned, the same individual cannot participate in the two programs. So when a child is enrolled in SSI, that child is removed from the size of the household that's used to calculate the TANF benefit. So the household size is a function, or the TANF benefit is a function of the household size. So what we're going to do is calculate a measure of the maximum potential gain for a household of having a child participate in SSI. That's going to be the SSI benefit plus any potential supplement in the state. Some states offer a supplement, and we're going to subtract off the change in benefit associated with reducing that household size by 1. So here I'm just providing a couple examples. So just to walk through this first row, for the state of Illinois, in 2009, the maximum SSI benefit was $674. The next 3 columns here show what the maximum TANF benefit would be for a household of 4, 3, or 2. And so for an example, if there was a household of 4 who had one child that was enrolled in SSI, their maximum TANF benefit would fall from $474 to $432. So that difference of $42 between those two is kind of the TANF benefit change that we're going to be subtracting. And as a result, you can see here the net gain for that household of 4 of shifting to the child to SSI would be the 632. Importantly, you can see that the net gain varies depending on what the household size is. And so this is the variation that we're planning to exploit. So we're going to use a variety of data sources. The primary data source is the National Survey of Children with Special Healthcare Needs. This survey is representative of children with special needs at both the state and the national level, and has a total of about 40,000 children with special needs. To my knowledge, it's one of the largest survey sources out there with such a robust sample of children with special healthcare needs outside of administrative sources. About 9% of respondents in the survey receive SSI. And importantly, this data also includes all the information we need to compute the instrument that I just mentioned, as well as key outcomes related to caregiver burden, including mental health measures, or some reports of self-reported mental health, and financial measures for the family. So we're going to merge on a variety of policy sources related to state policies for welfare, childcare subsidies, Medicaid benefits, and SSI supplements from the sources listed here on the slide. So of course, in order for this instrument to work, we need there to be variation in household size. So these two histograms show the distribution of household size in the survey, split by whether or not the household has a child who receives SSI. The median household size in both subgroups is 4, and you can see that there's variation on either side of that for each of the subgroups. Next, I'm just going to show a series of graphs showing kind of the geographic variation as well. So this just shows the maximum TANF benefit for a family of 3 in 2009, since that's the primary year of data that we're going to be using in this project. You can see, of course, the benefits tend to be lower in the Southeast and higher in the Northeast and on the West Coast. This graph we computed from the survey data we're using, and it shows the share of children with special needs in our survey who receive SSI in each state. And it's sort of the inverse of the prior graph, where there's higher concentration of participation in the Southeast. So again, this is kind of part of the motivation of this prior work looking at substitution between the two programs, although of course there's other regional factors associated with health and other benefits that could also lead to some of some of the drivers behind this pattern. So finally, this last graph shows our estimate of the net financial gain averaged to the state level. And again, you can see that there is variation across across states in this net financial gain, although it doesn't always follow that same geographic pattern that we saw before. So we think that this is allowing us to kind of separate out some of those geographic factors and really isolate on the financial gain in kind of developing our IV approach for this study. So this just shows our main IV formula here that we're going to be running. So the first equation is the first stage, where we're going to be regressing an indicator for whether the child participates in SSI on this measure of net financial gain, as well as a series of child characteristics and state fixed effects. And then in the second stage, we're going to regress a caregiving outcome of interest, whether that's self-reported financial problems, a need to reduce work in order to care for the child, or reports of need for mental health care on this predicted measure of participation. So of course, our main assumption for this exclusion restriction is that the net financial gain of SSI only affects these caregiving outcomes through the effect on SSI participation. Because we're using within state variation, we are going to be able to control for state fixed effects. We're also going to control for household size, and we have controls for other policies that vary within states. For example, childcare subsidies also vary with the size of the household, and so we've included measures of the maximum childcare subsidy for the household size. And those are all intended, of course, to control for these unobservable factors associated with the net financial gain. So this slide shows our first stage. So here we've scaled the net financial gain by 100. So you can think of these coefficients as showing the effect of an increase in the financial gain of $100. In columns 1 through 3, we're subsequently adding additional controls, measuring the severity of the child's health condition, as well as some of those state parameters that vary within states that I mentioned before. So as you can see, however, our coefficient is quite stable across the 3 specifications. So column 3 is our preferred and perhaps most conservative specification. And here we can interpret this as an increase in the net financial gain of $100 leads to a 2.6 percentage point increase in SSI participation. Relative to that baseline mean of 9%, this is a change of nearly 29%, so quite sizable increase in the probability of SSI participation. In columns 4 and 5, we restrict the sample to subgroups that are most likely to be affected by this SSI financial gain and most likely to be eligible for both TANF and SSI. So in column 4, we restrict the sample only to those households earning less than 200% of the federal poverty level. And there we see a larger effect of 4.7 percentage points. And then finally, in column 5, we use a measure controlling for, kind of restricting the sample to children with the most severe conditions, again, who are maybe most likely to be eligible for SSI, and see an even larger effect of 6.7 percentage points. So this is all suggesting that this net financial gain, again, is quite a relevant predictor for SSI participation. Next, we move on to the IV results. So here I've listed the main outcome in the header. So this is looking at whether the child's health condition has caused financial problems for the family. So here we're showing 3 regressions. First is the OLS regression, and the second column is the reduced form, and then in column 3 is the IV. So while we're seeing some evidence of this relationship in the reduced form, that the net financial gain is kind of reducing the probability that the family has financial problems due to the child's health condition, we aren't finding very precise estimates when looking at the IV. And I've listed the F-stat here. It's at just below 10, so it's suggesting that we may have a borderline weak instrument. But nevertheless, there's suggestive evidence that this is kind of working in the direction expected. The second main outcome we've looked at is whether the family reports that they've needed to reduce their work in order to care for the child. And again, we see kind of a similar pattern.
1 minute.
Okay, thank you. Yep, almost done. I appreciate that. Again, we see a similar pattern with unfortunately imprecise estimates in the IV results. We don't find any strong effects in mental health care. So just to wrap up, we do find that this net financial gain is a strong and relevant predictor of SSI participation and some suggestive evidence in the reduced form, but perhaps of a borderline weak instrument. So we're still at a fairly early stage in this work, and our next steps are to kind of think about ways to expand our data collection, to incorporate additional variation, and perhaps explore some other data sources that could be used in a 2-sample IV approach with maybe more precisely measured outcome variables of interest. Thanks so much for your time and attention, and thanks in advance to Manasi for her comments. So thank you.
Thank you. The next paper, we're going to the different art in the program. The next paper is the role of paid family leave in spousal labor supply responses to a disability or health shock. And it's going to be presented by Priyanka Anand, and it's co-authored with Laura Dague and Kathryn Wagner.
Great, thanks very much, and thanks everyone for being here. As mentioned, this is joint work with Laura Dague from Texas A&M and Kathryn Wagner from Marquette University. So when an individual experiences a disability or a major health shock, this doesn't just affect the person themselves, but it can affect all of the members of the family. So specifically, it can affect the family budget in terms of the lost income the person experiences from not being able to work anymore. They may incur large medical expenses. And if they need caregiving, caregiving can be costly, whether it is formal caregiving that they pay to have somebody help with basic functions, or even if it's informal caregiving through the opportunity cost of providing that care. So when there is a disability or a major health shock, family members need to make some decisions about their labor supply. And in this paper, we're really interested in those decisions between spouses. So we're going to refer to the person who experiences the disability or major health shock as the spouse, and the person who is making their labor supply decision as the potential caregiver. So the potential caregiver faces a trade-off in terms of their labor supply decision. And one option is that they can stay at work and earn money and pay for some of those medical expenses and potentially pay for a formal caregiving for their spouse. Another option is that they can reduce their labor supply and provide informal caregiving for their spouse, which may be preferred and more comfortable for the spouse. There has been some past research that has looked into this empirically, and it tends to find that labor supply tends to go down after a spouse experiences a health shock. And I think Yulia is actually going to present later in the session some work that looks at this question. But one thing that hasn't really been looked at is the role of paid leave in this labor supply decision. So paid leave programs provide either partially or fully compensated time away from work in order to provide caregiving for family members. So people often think of paid leave as being just for children or newborn children, but you can also use it for a family member who experiences a health shock. There is no federal requirement to provide paid leave but some states do have mandated paid leave programs. Specifically, California and New Jersey have had a mandated paid leave program since 2004 and 2009, respectively. There are other states, Rhode Island, New York, Washington State, and DC, that have implemented their mandated paid leave programs more recently. And there are 3 more states that have passed legislation for paid leave and will be implementing them in the next few years. And in this paper, we're going to be focusing on California and New Jersey, who have had these programs for the longest. I do want to draw the distinction between paid leave and FMLA. FMLA is a federal policy that provides unpaid job protected leave. So employers must give you a job upon return to work, but they don't have to pay you for the time that you are away. So when thinking about this relationship between paid leave and long-run labor supply, the predictions are actually theoretically ambiguous about whether paid leave would increase or decrease labor force attachment. So on the one hand, paid leave laws may decrease labor force attachment among these potential caregivers if, for example, it increases the duration of leave that the potential caregiver takes to provide informal care, so they are away from the labor force for longer, and the longer that they're away, their human capital may depreciate, and so they may not be able to go to work, or they may decide not to go to work. So this is one of the fears, that paid leave would decrease labor force attachment. But on the other hand, paid leave laws may increase labor force attachment if, for example, it allows a potential caregiver to improve the financial and household stability so that they can go back to work once they have improved their financial state and the household. It also could make these potential caregivers more productive if having paid leave results in higher job morale or tenure. And of course, these relationships also can be affected by the type of health shock. For example, a shorter health shock versus, or a more severe health shock may have a different relationship. And also characteristics of the potential caregiver could also affect this relationship. So most of the empirical work that has tried to look at which direction that paid leave has on labor supply has focused on women's careers after childbirth. But our work is contributing to this literature by looking not at childbirth, but looking at the relationship between paid leave and labor supply decisions after a spouse's disability or health shock. So specifically, our paper looks at 3 research questions. We start by looking at how a spouse's disability or health shock affects the labor supply decisions of the potential caregiver, just overall, not looking at paid leave. And then we move into looking at how does access to paid leave affect these relationships between the labor supply decision and the onset of a spouse's disability or health shock. And then finally, we look at whether these impacts differ by various subgroups, such as by gender, education, prior earnings, and FMLA eligibility. The data we use is a survey of income and program participation, the SIP, and we use the 1996, 2001, 2004, and 2008 panels. So this is why we look at California and New Jersey primarily, because they passed their paid leave mandates during these periods. The SIP is a household survey that importantly collects information both on the potential caregiver, but also the spouse, and it follows them for approximately 4 years. We're able to use the information in the SIP to define the spouse's or identify a spouse's disability or health shock in 3 ways. So the first measure of having a disability or health shock is having a work-limiting disability or chronic health condition. So we use 2 questions to measure this. The first is whether the person reported having a physical, mental, or other health condition that limits their work. The second question we use is if the person is not working, they're asked why not. So we record somebody as having a work-limiting disability or chronic health condition if the reason for not working that they say is because they had a disability or chronic health condition. So this is our measure of a work-limiting condition that we consider to be more long-term, more severe. Our second definition of a disability or health shock is more of our shorter term condition. So it's a work limiting illness. And these people reported that the reason that they were not working is because of an illness. And then finally, we look at whether the person reported having any disability. So, and that would be if they reported having at least one of 6 functional limitations. So this would be if they had difficulty hearing or with their vision or independent living. There are 6 categories. And that is available only in the 2008 panel. So we have these 3 definitions. 2 of them are work limiting disabilities or health shocks, and one of them is not dependent on being work limiting. And so you may interpret that as not affecting the family and potentially not affecting the family budget quite in the same way as the work limiting health shocks. So once we've identified people who have a spouse with who experiences a health shock, then we can implement our empirical strategy for answering our research questions. So the first research question is just what happens with the labor supply decision after the shock. For this, we do an event study framework where we follow our outcomes of interest for 6 waves before the event and 6 waves after the event. So 6 waves is equivalent to about 2 years before and after. We are able to control for individual calendar year, state calendar year fixed effects, as well as the number of children. And we omit the wave before the shock occurs. So all of these event time dummies are relative to the wave before the shock. And we limit our sample to those who are between ages 18 to 64, had a spouse who experienced the health shock, and also just those people who had worked at some point in the 2 years before the shock. The dependent variables of interest, there are 6 of them. The first one is whether the person reported working all weeks in the wave. One thing that's very important to keep in mind with the SIP is that it doesn't actually ask explicitly about paid leave. So if somebody is taking paid leave, they will still report that they are working in that wave because they do have a job, or they're reporting that they have a job. And so they will have a 1 for this. It's only if you take unpaid leave that you won't be counted in this measure. Similarly, for the second measure, that is if the person worked at least 1 week in the wave. Again, it doesn't ask explicitly about whether you have a job and you're on paid leave. So if somebody is taking paid leave, they will still respond to this affirmatively, that they are working at least 1 week in the wave, even though they're taking paid leave. Our third measure is if the person reported that the reason that they are not working at all is in order to provide caregiving during the wave. So this is our measure of leaving the labor force because they're providing caregiving. Our fourth measure is that they're working less than 35 hours to provide caregiving. So maybe they haven't left the workforce, but they're reducing their time spent working. And then we look at average earnings in the wave and whether the person is working full time, defined as over 35 hours, in all weeks in the wave. Then for our second research question, we bring in the question of does paid leave affect this relationship between labor supply decisions and spouse's health shock. And so we use a similar framework, but we bring in a diff component to the event study. So again, we look at labor supply decisions before and after the health shock, but we interact each event time with whether the person lives in a state that has a paid leave policy. Another difference between this framework and the first research question is that we restrict our sample only to states that either offer paid leave currently or states that will offer paid leave in the future. So our comparison group are those states that are going to eventually offer paid leave but don't quite do that yet. And this is just to ensure that they are kind of similar in their labor market and that they're open to having a paid leave policy but haven't done so yet. And we also use this framework to answer our third research question, which is to look at this model separately by gender, by education level of the potential caregiver, and earnings of the potential caregiver in the wave before the shock, and FMLA eligibility before the shock. And so for this model, our identifying assumptions is that the timing of the health shock, the timing of the health shock is unrelated to the passage of paid leave, so strict exogeneity, and also a parallel trends assumption that we'll look at by looking at the coefficients on the periods before the health shock. I'm going to skip the descriptive statistics in the interest of time and just jump into the results. So in this first set of tables, these are for potential caregivers whose spouse experienced a work-limiting disability or chronic health condition. So here you can see there are the 6 outcomes. And if you look at the first 2 outcomes for working all weeks or working at least 1 week, the trends before the shock are pretty stable for both of these outcomes. And then you can see there is a drop in the likelihood of working all weeks after the spouse experiences a work-limiting disability or chronic health condition, or working at least 1 week. We also see an increase in the likelihood of not working to provide caregiving. This one's a little bit harder to interpret because we do have this pre-trend, although it reverses direction. So we do think there's something going on here. And generally, we conclude that a potential caregiver whose spouse experiences this work-limiting disability or chronic health condition is less likely to work and is more likely to be providing caregiving. The next set of graphs are for individuals whose spouse experiences a work-limiting illness. So this would be a shorter condition than the last set of graphs we saw. And again, we see that there is a decrease in the likelihood of working at least 1 week. We also see a decrease in the likelihood of working all weeks, although again, we have this kind of reversal in trends. But generally, we conclude that if you have a spouse who has a work-limiting condition, whether it's short-term or long-term, you are more likely to reduce your labor supply. In contrast, when we look at people whose spouse has any kind of disability, not necessarily a work-limiting disability, we don't actually see a large response in the labor supply. And perhaps this is because the family budget is less affected by having any kind of disability as opposed to a work-limiting disability. Next, I'm going to turn to the results for paid leave. So this is the impact of paid leave on labor supply decisions for those whose spouse has a disability or chronic condition. And you can see that we don't actually see a large response. So there's not a big difference between individuals who have—
You have 1 minute.
Oh, thank you. Who have access to paid leave and don't. And I'm going to go through the next slides pretty quickly because you can see it's similar for all types of spouses' health shocks. So again, if we look at those who have a work-limiting illness, paid leave doesn't seem to have a very large impact on the response. And similarly for having any kind of disability, we don't see large differences between those who have access to paid leave and those who don't. Again, with when we look at the subgroups, those findings are very similar to our overall results, where we don't really see a strong impact of paid leave for any given subcategory of potential caregivers. There may be some impacts for women, but the patterns aren't consistent enough for us to draw definitive conclusions. So to conclude, our study provides evidence that potential caregivers, they do tend to reduce their labor force participation after a spouse's work-limiting health shock, not so much any kind of health shock, but mostly a work-limiting health shock. And while paid leave laws in California and New Jersey don't seem to further reduce labor force participation, as some feared, we also don't find a lot of evidence that they mitigate the negative impacts of the health shock. And some reasons why we think maybe we don't see an impact of these paid leave laws are potentially people usually think of these of paid leave as being for maternity leave, and so potentially people are not aware that they can use it for spousal care. Possibly cut me off.
Wrap it up.
Okay, yes, I was just going to say maybe the short duration, or people already have access through their employer, maybe other reasons why, but our future work is going to try to better understand who has access to paid leave and why it may not be having an effect that we expected. Thank you.
Thank you. Manasi Deshpande will discuss these first 2 papers.
Great, thank you. Let me share my screen here. All right, it's a pleasure to discuss both of these papers today. Thank you so much for inviting me to do that. So I'm going to start with Stephanie's paper. And I really enjoyed reading this paper. I think it's a really important paper for reasons that I'll touch on in a moment. So just to give you an overview of the paper, again, Stephanie did a great job, but just to give you a summary, this paper is trying to estimate the effect of child SSI receipt on parent mental health and household financial outcomes. And they're going to use the National Survey of Children with Special Healthcare Needs and variation in the financial gain from SSI relative to TANF across family size as an instrument for SSI receipt. In terms of their results, they find a pretty strong first stage relationship between financial gain from SSI receipt relative to TANF and SSI receipt. And their IV estimates are going to be somewhat imprecise, even though the OLS, or the reduced form, is more precise. So I just want to start with the motivation for this paper. I really like the question that this paper is trying to address, and I think it fits into a broader literature that we've seen in the last decade or two, showing that transfer programs can have pretty substantial effects on outcomes that are not targeted. And in fact, sometimes their biggest effects are on outcomes that are not targeted. So some examples of that, we know from Moving to Opportunity that one of the first effects that researchers were able to pick up from MTO was effects on parent anxiety and mental health. So they didn't initially find effects on the kids themselves, although subsequent follow-up did find effects on kids. But one of the first effects that they were able to detect was that moving to a lower poverty area reduced parent anxiety, right? which makes a lot of sense. And there's also been a substantial amount of work on Medicaid and Medicare. And of course, these programs, Medicaid and Medicare, do not insure your health, they insure your health expenditures. And so, perhaps it's not surprising, but we needed the evidence to show us that some of the biggest effects of Medicare and Medicaid are not on physical health outcomes, but rather on financial outcomes, reducing the likelihood of adverse financial events like bankruptcy, and then not surprisingly, improving mental health, presumably because people are not as worried about going into bankruptcy or being evicted or something like that. So I think this fits really nicely with this broader literature that takes seriously that transfer programs have a large insurance value. And by insurance value, we mean, avoiding this tail consumption risk and also the mental distress that goes along with that risk. So more specifically in the context of childhood SSI, I think this is an important paper because we just have very limited evidence on child SSI and broader household outcomes. So I have some forthcoming work looking at the effects of adult SSI on financial outcomes, but as far as I know, there's no work on the effect of childhood SSI on household financial outcomes. Stephanie mentioned this paper by Gaulke and co-authors looking at some broader effects of childhood SSI on households. But Stephanie's paper is thinking about also parent mental health and financial outcomes, and given what we saw from MTO and Medicare and Medicaid, those effects could be substantial. So in terms of the method, so I think this paper is very creative in thinking about variation in SSI. One of the issues with a federal program like SSI is just that there's very limited variation in this program. And so that makes it challenging to identify the effect of SSI on household outcomes or really any outcomes. And so what they do in this paper is they use variation in the financial gain from SSI relative to how much a household would be able to get in TANF benefits across family size. And they use that as an instrument for SSI receipt. And the key assumption here is that the relative financial gain from SSI relative to TANF is going to be correlated with those household outcomes only through the child's SSI receipt, right? And so we really want to think about, are there other ways in which this financial gain could be correlated with outcomes, right? And so one thing that we might be concerned about is that if most of this variation is operating through household size, the household size could either directly affect household outcomes, or it could affect household outcomes through other programs. So for example, we know that public housing in many places, right, will those either priority for public housing will be different based on household size, or the amount of the public housing benefit itself could be different based on family size. And so that's something that we would want to think about. And the other thing I was thinking about was, could it be the case that if we're primarily relying on family size or household size, that we could be comparing families with different compositions. So if 3-person families are more likely to be single parent headed than 4-person families, if 4-person families are more likely to have 2 adults and 2 children, is that potentially confounding? Because obviously, right, the number of parents in the household likely makes a difference for household outcomes. And then the other thing is thinking about, I remembered this this nice paper by Adam Looney and Dave Manoli, in which they looked at EITC variation. So many papers have used the household size, so differences across households and size, to look at the effects of the EITC, because families with 2 children are eligible for more in benefits than families with 1 child. And they have a nice paper in which they point out that another thing that often differs between families with 2 children versus 1 child is the age of the youngest child. So the age of the youngest child is going to be younger for the two child households than for the 1 child households on average. And so especially in the EITC literature, where a lot of what people are looking at is the mother's labor supply, right? You might imagine that the age of the youngest child is going to make a big difference for mother's labor supply. And so that's another potential issue. So the main thing I was thinking about was, well, how could the authors get around this issue? I think, to the extent that there is variation within state across households after controlling for household size and composition, that seems pretty important. I don't know, I would be interested to hear from Stephanie if there is variation left after controlling for those things. But maybe the answer is, unfortunately, we have to go back to using a cross-state variation and sort of thinking about the trade-off between, cross-state isn't ideal either, but is it, better or worse than using the within-state variation? So I would love to talk to the authors more about that. And then finally, in terms of interpretation, I thought this was pretty interesting, right? Who is affected by this? Who is moved by this instrument? Which households are we talking about when we talk about people who are kind of in this risk set of moving to SSI versus TANF based on the relative gain from SSI? And so these households, should be eligible for both, right? And they're probably going to be households, if they're eligible for both, that are headed by a single mother who is not working, because usually that has to be the case for TANF, but the mother is able to navigate the complexities of SSI and TANF enrollment and sort of make that active decision between the 2 programs. And so, I've tried to look in the past for information about the overlap between SSI and TANF, and there isn't actually a whole lot of work out there that I know of. So these are 2 studies that from the Social Security Administration that I know about that suggest limited overlap of these programs for adults. Now, I suspect that the overlap is much, much higher for the particular families that Stephanie and Lynn are studying. And so I would just love to know more about who those households are. They're eligible for both and are sort of in this risk set. And my guess is that, in fact, this is a really relevant question for those households, because they might be the most vulnerable households, and so the households for whom we expect this relative difference in SSI benefits versus TANF benefits to matter. So those are just some thoughts on interpretation. But I really enjoyed this paper and I think it's a fantastic question and something that we need more work on. So I applaud the authors for that. So that being said, let me go ahead and move on to Priyanka's paper. And this is another paper that I thought was just the question is just fantastic. There's been as all of you know, a national discussion about paid leave, and we really need more evidence on this question from the state level and what effects these policies have had. And so just to summarize their paper, what they're trying to do is determine whether paid leave laws affect caregiver labor supply response to the disability or health shock of a spouse. So as Priyanka was talking, I was trying to change my slides to correspond with her use of spouse and caregiver. I think I got all the references, but I'm going to try to stick to her terminology. So they're going to estimate the event study of the caregiver's labor supply outcomes with and without paid leave laws, and they're going to use several panels of the SIP to do that. And they're going to show us baseline outcomes with no paid leave, where we see clear reductions in caregiver employment following health shocks. And then, I'll talk about this a little bit. Or is it imprecise or is it zero effects of paid leave relative to that baseline? So in terms of the motivation, so the purpose of these laws is to improve financial stability and labor force attachment of households that experience these kinds of health and disability shocks. And as I mentioned, we have, even before the pandemic, increasing policy interest in paid leave at the federal level. So it's really important to understand whether paid leave actually improves these outcomes, given the kind of stated purpose of these laws. And it's important. One of the reasons I really like their paper and their focus on the caregiver is that health shocks affect all members of the family, right? We call it both family and medical leave for that reason, that it could be about your own medical condition or about a household member's medical condition. And as Priyanka pointed out, right, the caregiver's labor supply response could reflect either direct effects of the policy or indirect effects from complementarity with the spouse. So if paid leave is affecting what the spouse does, then it could also indirectly affect what the caregiver does. So in terms of method, they're going to use an event study design, which I thought was fantastic. I think it's just the right tool for this question. And I liked that they show us a baseline response first, and then on top of that, show us the effects with paid leave. I would have really liked to see first the spouse's own labor supply responses before the caregiver, just to get a sense of, to the extent that this is supposed to have a direct effect on the person who experiences the shock, what is that effect? And that would also help us, I think, interpret what is happening with the caregiver. In terms of the effects, I think Priyanka interpreted the effects as zero effects, which could well be true. I was thinking about, when I was reading the paper, are these zero effects or are they imprecise effects? I am actually really excited to see a follow-up version of the paper where they can include more states, as more states are adopting these policies. I think part of the issue here is that there's just 2 states over a somewhat limited span of years, and I think that you could definitely have more precise effects over once you're able to include those additional states. And the other thing I was thinking about was, it's possible that we'd see heterogeneous effects here, right? And that those heterogeneous effects could actually cancel each other out. And it really depends on what the counterfactual is. So if the counterfactual, what you would have done if there was no paid leave is quitting your job or being fired because you experienced this health shock, when paid leave is introduced, what we would expect to see is more hours and higher earnings and employment rates, right? But if the counterfactual is instead that you don't quit your job, you sort of suffer through it because there are no other options, what we would expect to see when paid leave is introduced is fewer hours and potentially lower earnings, but similar income because you're getting income from this program, right? And so it is possible that, depending on the counterfactual, that these are that they're heterogeneous effects, and the heterogeneous effects could in principle cancel each other out. And so it seems important to, I know the sample right now is very limited because of the state issue, but it seems important to think about that possibility. Cool. Sorry, something just cut out. Okay. So then finally, just on interpretation here. So, you know, I was also thinking about, kind of related to that comment about counterfactuals, how do we think about the welfare effects of this policy? So as I was reading this paper, I was thinking about, you know, what we often discuss with respect to social insurance and using consumption as an outcome. And there are, you know, a lot of papers have made this point before, but the one that I often think about is Chetty and Looney, 2007. You know, the point that without social insurance, it's possible that households are undertaking costly consumption smoothing strategies to stabilize their consumption. And so in Chetty and Looney, they give the example of, you know, households in developing countries, you know, potentially taking their kids out of school when a parent loses a job. And so if we were just looking at the consumption data, it would look like there was no change in consumption when the parent loses their job. But it's because the household is engaging in very costly consumption smoothing activity, because that household is starving, basically, right now, has no other options, is very risk averse. And so in that situation, social insurance can improve welfare, even if we don't observe an increase in consumption. And I think, right, there's an analogous scenario here, or analogous caveat here, where it's possible that without paid leave, right, households are kind of suffering through their jobs. So they're holding on to their jobs despite the spouse or the caregiver, you know, the household experiencing this health shock. And that's coming at the expense of their well-being, either mental or physical. And so it is possible that even if we don't see employment effects, that paid leave could still improve welfare, right? And so I think this paper is a really important start to understanding the effects of paid leave. And in addition to looking at employment effects, I think it's also important to remember that we also want to look more broadly at measures of well-being. So even if that's not something that the authors can do in this paper, because those measures are limited, I think it's just really important for us as researchers to keep in mind that seeing no employment effects doesn't necessarily mean that this policy didn't have any effects or didn't change people's well-being, right? That it's important to take into account other measures of well-being. So let me stop there, and thank you very much for the opportunity to discuss.
Thank you. The next paper is entitled "The Impact of Childhood Health Shocks on Parental Labor Supply" by Tine, Eriksen, Amanda Gaulke, Niels Skipper, and Jannet, Svensson, and Mandy Gaulke is going to present the paper.
All right, hopefully everyone can see the slides here now. We can see the slides, hopefully. Okay, great. So yeah, I'll be talking about the impact of childhood health shocks on parental labor supply. This is joint with Tina Eriksen at VIVE, Niels Skipper at Aarhus University, and Jannet Svensson at Copenhagen University Hospital. We'd like to thank Independent Research Fund Denmark for providing grant support for this project. There are many children, and this kind of ties in nicely with the other papers that have presented so far, that are diagnosed with chronic health conditions and disabilities, but not all of them are actually going to have a health condition that is going to result in government transfers being tied to that diagnosis. However, a lot of the literature on child health and parental labor supply focuses on cases where the diagnosis results in government transfers. The reason for this is there's a concern that parents may be overestimating the severity or over-reporting the severity of the childhood health shock if they would like to work less or don't want to work at all, and essentially blaming that on the child health when that's not really what's causing the reduction in labor supply. But if we're only looking at children where the case is so severe that it's resulting in government transfers, we're only looking at a subset of families that could potentially be impacted. And ex ante, it's less clear that for health conditions or disabilities that are not qualifying for government transfers, would parents still be significantly or economically impacted in those cases? And so we should care about this to get sort of more a full picture of what's happening to these families that have children that are having these chronic childhood health conditions. This matters because these health conditions have been shown to be important in explaining the income health gradient. So what we're trying to contribute with this paper is thinking more broadly about what's happening to families, but not just focusing only on the subset where the health condition or disability is actually going to be severe enough that it's qualifying for government transfers. And so what we're doing in this paper is looking at whether parental labor supply is affected when a child receives a severe negative health shock, but that health shock does not result in government transfers. And so we're estimating a fundamentally different treatment effect that has been done in the related literature, which has looked at the most severe cases and government transfers, and we're looking at slightly less severe cases, no government transfers. And the way we're going to estimate these effects is to use type 1 diabetes as a plausibly exogenous disability shock. So why type 1? There's lots of chronic health conditions and disabilities that you could think could be potentially used here. So give you some background on why type 1. And so first off, people may not realize there's actually multiple types of diabetes. When you hear talks in the media about you need to exercise and eat right, otherwise you'll get diabetes, that is referring to type 2 diabetes. For type 1, the exact cause is actually unknown, and it has not been shown to be related to lifestyle like type 2 diabetes is. There's also a very low degree of inheritability, so it's not the case that parents would be likely reducing labor supply because they themselves also have this condition. The medical research has documented, for example, if the mother has type 1, there's only a 3% risk that the child will also get it. So it's unlikely that this genetic component is playing a large role, unlike some other health conditions. We also don't have to worry about diagnostic trends where maybe some kids are able to just be undiagnosed, but they still have the condition, because without insulin treatment, you will die. Before insulin treatment was available, the average life expectancy was only 2 years. So we do not have to worry that our control group is being contaminated by children who actually have diabetes, but just don't have that diagnosis. I'll show you in the data section, it's not strongly predicted by socioeconomic status. And importantly, to address that concern that parents may be overestimating or over-reporting the severity, type 1 diabetes is severe enough that it meets the definition of disabled according to the Americans with Disability Act. But importantly, in Denmark, the setting of the study, it does not qualify for any sort of welfare or government transfers as a result of the diagnosis. Taken together, we feel that these make type 1 diabetes an ideal candidate to be able to estimate these effects on parental labor supply in the absence of government transfers. There's a huge literature on thinking about caregiver impacts and specifically parental labor supply. Just in the interest of time, I'll focus on one other recent paper using Danish data, which is Gunstenstein and Steinskrim-Dottier. But our papers are estimating, again, two different treatment effects. They are looking at the most severe cases. And so how in Denmark do they define severe? So in their in that paper, in order to be able to qualify for these government transfers, it's determined that the children are unable to attend daycare or school, and therefore it is in the best interest of the child to receive care from the parent. Type 1 diabetes, even though it meets that definition of disabled, children can still attend daycare or school, and so they're not qualifying. And so there is a distinction clearly in their policy about which side you're on here. And their paper certainly is important to document impacts on parents when government transfers are available, but that need not apply in all situations. So it's important to just have a more complete understanding of what's happening to different families. So in the Danish context, we would think based on the Gould theoretical model that there'd be a decrease in labor supply because type 1 diabetes is much more time intensive than financially intensive. So the medical literature has clearly stated that there is a time burden on families who are helping children diagnose or manage their type 1 diabetes. The literature even states here that even high school students should not be expected to independently provide all of their own diabetes care. So it is expected that there is a time cost that's being imposed on parents. Furthermore, if the child's diabetes is not well controlled, according to Jannet, parents can, and in fact, they do report parents for child abuse or child neglect. if the child's diabetes is not adequately controlled. So there's that extra incentive to make sure that parents are really helping their child manage their type 1 diabetes. In the Danish context, there is universal healthcare financed through taxes, so the costs are much lower than those in the United States. All of the medical aids, primary care visits, hospitalizations, those are all provided free of charge. However, you still do have to pay for medicine. Insulin is not free, but it is considerably cheaper out-of-pocket costs than one would pay in the United States. So their average yearly out-of-pocket expenditure is only around $240. The data that we use is from Statistics Denmark from 1998 to 2017. We have the clinical registrar, Dan Dague kids. Jannet is in charge of this, and so they make sure that pediatric endocrinologists throughout the entire country of Denmark are uploading data about their patients. And so we have information like the exact date of diagnosis. We know the exact diagnosis, meaning we can rule out, it's not that they have type 2, we know for sure that they have been diagnosed with type 1 diabetes. Through the Danish equivalent of a social security number, we're able to match children with parents, and then we have able to get a lot of information on parental labor market outcomes, educational attainment, number of kids in the household, those sorts of things. And so this is just some descriptive statistics. Looking at the mother, in the paper we have father also. A lot of these characteristics, the treatment and control group look very similar, like whether the parents are living together, if they're on social assistance, if the mother is working part-time. The main difference here is that immigrants are much more likely to have children who are in the control group where they're not getting the diagnosis. If we instead run this as the probability regressions, where this is the probability of a diagnosis in 2 years to more focus on the timing, again, immigrant seems to be the one thing that's kind of standing out. And so the main threat to our identification would be if that underlying unknown cause of type 1 diabetes was in some way related to parental labor supply, and that was what was actually causing the diagnosis. And so to try to convince you that the parents who are in our treatment and control group look very similar, this is the raw log wage income for mothers. You can see both the level and the trend prior to diagnosis are extremely similar, suggesting that it's not that one of the groups just had different labor supply or wage income previous to the diagnosis. And you can see here descriptively what we'll show you with the event study, that around that time of diagnosis, you see this gap between the treatment and control, and maternal income declines for the treated mothers at least 10 years post-diagnosis. Similarly, for fathers, there's not a difference in the level or trend prior to diagnosis. And you can see here again, the results we'll show you with the event study, which is the impact on fathers is much more transitory. You just have that impact around the time of diagnosis, a couple years after, and then these fathers are able to essentially bounce back and look very similar to the control fathers. To further convince you that these children are not just sicker on average, if we look at APGAR scores or probability of low birth weight, we do not see any differences between the children who will and will not be diagnosed with type 1 diabetes. So what we're going to do is match all of our treatment kids to 5 controls based on being born on the exact same day and being the same sex, and then estimate an event study. And so the control kids are all going to get a pseudo date of diagnosis based on the actual diagnosis that of the child they're being matched to. And so we can see 5 years prior to 10 years after diagnosis, similar to the related literature. This is relative to the year prior to diagnosis. Then we have our time dummies for the control group, year effects, and we're controlling for immigration because that is the main characteristic where our balance test is not actually looking the same. We, in the paper, add all the other controls in and it doesn't really matter. We find the same results regardless. And we're going to be clustering our standard errors based on having multiple observations per person over time. And since this is administrative data, we do not have missing data on these labor supply outcomes or parental wages. And so on the top panel here, this is the employment effect on mothers. We can see that there's no effect on employment, but in the bottom, it's looking at wage income. You can see prior to diagnosis, there's no gap between the treatment and control, but after diagnosis, there's a decline in wage income. If we instead run this as the diff and diff, you get between a 4 and 5% decline in wage income that persists at least 10 years after diagnosis for mothers. Well, why is this happening? Because mothers are more likely to be shifting from full-time to part-time work. And so that's the top figure here. In the year of diagnosis, there's about a 12.5 percentage point increase in the probability that a mother will work part-time. After that, you do see the estimated effects are smaller in magnitude, but there is this persistent effect that these mothers are more likely to be working part-time after diagnosis. On the bottom, we look at probability of working in the public sector because this is known to be more family friendly. So it may be easier if you have to take time off to take children to appointments or drop off medication or take phone calls from teachers. The effects there are kind of marginal if we aggregate them into more of the diff and diff. It's kind of depending on the exact specification there, it's either below or just above the 5% cutoff. In terms of fathers, their top showing no impact on employment. For the wage income, there is that decline in the year of diagnosis and 2 years after diagnosis. But as we could see descriptively in the raw data, fathers are then able to rebound and get back to looking more similar to the control fathers after that. Fathers are also more likely to shift to part-time work in the year of diagnosis. However, the magnitude here is much smaller. It's only a 3 percentage point change versus a 12.5 percentage point change. And that you can see that's mainly just driven by that year of diagnosis, and then fathers are shifting back to full-time work. And we're not seeing any impact on the probability of working in the public sector for fathers. And so in the paper, we do a bunch of different robustness checks, doing it with difference and difference. We do individual fixed effects in the diff and diff, in the event study, control for all of the other characteristics in that table. Our results are quite robust. We consistently find that mothers are shifting, more likely to shift from full-time to part-time work, and they experience these declines in wage incomes that persist at least 10 years after diagnosis. If we condition on the parents living together in the year prior to diagnosis, we do not find any overall impact in family income, suggesting that parents may be able to coordinate their responses to try to keep the overall family income relatively constant. However, our results showing this different impact by which parent it is has important implications for the gender wage gap. So Clevin and co-authors find that about 80% of the gender wage gap in Denmark is attributed to children. If we compare our estimated wage impact to the estimated impacts of the motherhood penalty, we find that our impacts are around 16 to 21% of that motherhood penalty. And so this suggests that child health, even in cases where it is not severe enough to be qualifying for government transfers, still could be contributing to this gender wage gap. Importantly, our impacts are different than those found in Gunstenstein and Steinskrim-Datier. They find that their impacts grow over time, whereas we showed the impacts were largest around that time of diagnosis. They also found more impacts on fathers, where we did not generally find impacts except for that very transitory hit. And they also found impacts on mothers, both on the intensive and extensive margin, where we're just finding the shift from being more likely to move from full-time to part-time. So it does seem that the context matters here.
1 minute left.
All right, great. And so just to summarize here, we do find that mothers are impacted when their child is diagnosed with type 1 diabetes. The impact on fathers is much more transitory. And so even though the overall family income is not changing, this could be an important contribution to the gender wage gap. We're also looking at then thinking about our siblings impacted if parents are trying to now juggle this additional disease management. And so we could think that there could be other spillovers, even though their family income may not be changing overall. And this contributes to literature by documenting what happens when government transfers are not available and showing that that is different than the findings in the related literature that's looking at cases where government transfers are available. And thank you for your time, and I look forward to your comments and questions.
Oops. Thank you. The next talk is by, the paper is by change in title, Caregiving and Labor Force Participation, New Evidence from the SIP by Nicole Messis, Matt Messel, and Yulia Truskanovsky. And Yulia will give the presentation.
All right, am I sharing screen? Okay, great. Thank you. Right, so this is different than what was advertised in the program. So if you're here for UI, I apologize. It's been a weird year, and thank you to Till for being flexible. So I want to acknowledge my co-authors, Nicole Mastis and Matt Messel, and then make sure I can move this. There we go. Here is the SSA disclaimer. Okay, so growing need for long-term care is the reality of a rapidly aging population. About 1 out of every 5 people living in the US is going to be 65 and older in about 10 years. And 70% of those age 65 will need assistance with some basic functioning in their lifetime. And of course, as we've seen in this panel, caregiving is not just limited to the elderly. It's a reality for almost everybody. Formal care, either in a institutionalized setting or in the home where you're paying somebody, is quite expensive, right? And because of that and a number of other reasons, the majority of long-term care is provided informally by family members. And of course, as we've seen again from the other presentations, caregiving can interfere with work. So if you've perused the New York Times in the last few years, you might have seen a headline like this: "Why aren't more women working?" Well, they're caring for parents. And we have some empirical evidence to show that this is indeed the case. So we know that caring for family members impacts labor supply on the intensive and the extensive margin. But causality is hard to establish here without clear exogenous shocks, and existing evidence is somewhat mixed. We know that economic conditions can also impact caregiving. Right, so we have some reverse causality as well. Much of what we know about caring, in particular for the elderly, so for aging spouses or parents in the United States, comes from the Health and Retirement Study, which is a biennial panel. So we're able to observe outcomes, static outcomes over 2 years. Or I should clarify that most papers using the HRS are looking at static outcomes. And in this paper, we're interested in thinking not about just does caregiving impact labor supply, but how soon do caregivers, right, family members who start caregiving stop working, retire, and see wage decreases. Right? This is hard to observe. You need high frequency data where you're able to observe both caregiving outcomes and employment outcomes. So Priyanka gave us a great overview of attempting to do that with spousal care, right? And to follow on to that paper, I think this is particularly important as we're trying to think about the effects of workplace policies like paid family leave, right? So unlike taking care of infants, where the trajectories are well known, in most cases well defined, right? Taking care of adults with disabilities or aging adults is likely to have very different trajectories. And so in this paper, we want to know, what do employment outcomes of caregivers look like in the months and years before and after caregiving starts, right? So even before thinking about the impacts of policies, we simply want to think about what these trajectories look like. And our approach here is going to be to construct a longitudinal data set combining retrospective caregiving information with labor supply information. So we're going to be using the SIP, and we're going to link the SIP to administrative data. Unlike the other papers in this panel, we are going to be relying on self-reported caregiving behavior rather than observed disability of somebody who needs care. Right? And we're going to explore multiple panel data strategies, and we're thinking about employment outcomes before and after caregiving. So again, using the SIP, we're going to be using the 96, 01, 04, and 08 panels. So those are popular panels to use. And I'll focus on the fact that we're going to use the SIP is longitudinal, so it surveys households every 4 months over 4 to 6 years. We're going to be using the informal care module, which is a cross-sectional module. So every participating households gets this module once per panel, about 2/3 of the way in. And this module has two questions that are going to be important. So the first is, do you provide any unpaid care to a family member or a friend who has a long-term illness or a disability? And when we pool those 4 panels, about 5% of the sample, almost 13,000 individuals, report that they do provide some sort of care. And then they're asked how long have they been providing this care? And they can say that they started caregiving in the past year, they've been caring for a year, they started 2 years ago, or they've been caregiving for 3 years or more. And just under half the panel has been providing care within the last 2 years. And for those individuals, right, those adults who are caring for other adults, started caring for other adults within the last 2 years, right, we can use that retrospective caregiving information to backdate the start of their caregiving spell within the SIP panel. Right? And so then we have monthly and wave by wave observations of their employment outcomes for the duration of the SIP panel. And then we have a binary indicator for whether or not they're caregiving at any point in the SIP panel. Now, we don't see the end of a caregiving spell, right? That's a limitation. So we see caregiving as an absorbing state. Right? And then we take this panel and match it to the SSA detailed earnings records, which allows us to observe annual outcomes for caregivers for up to 10 years before and up to 8 years after they are observed in the SIP panel. Okay, so I'm just going to jump in and show you a bunch of pictures. So the first thing that we do is look at a very basic event study model where we're just looking at trends in a number of outcomes for caregivers before and after they start caregiving relative to the year before caregiving starts. Okay, so I'm going to focus today on administrative data. So our outcomes are binary indicator for employment, continuous earnings. These are a little bit out of order. So self-employment earnings, right? These are pulled from administrative data. And then any claiming of old age or survivor benefits, and then disability benefits. So you'll notice probably 2 things first. Right away. The first is that there does appear to be kind of a discrete change in outcomes for a lot of these outcomes right around year 0, right, when we think the caregiving spell started. So again, we're relying on self-reported caregiving. So it can be hard to sort of interpret what exactly that means, but you can see that we do seem to be capturing the right time frame. The other thing you'll notice is that we see pretty dramatic pre-trends in a lot of these outcomes, right? So we see employment trending downwards for 10 years, right, before a self-identified start of a caregiving spell. Right, and we see similar things for earnings, and we see, for example, disability claiming trending upwards. Okay, so I can show you these pictures by age. I'm not going to focus on age. I'm going to show you quickly by gender, only to highlight that we see some really interesting heterogeneity by gender. So, for example, if you look at employment, right, we see that female caregivers, right, we see a decrease in employment for the first few years after the start of a caregiving spell, but employment rebounds, right? Whereas, and female caregivers see kind of much less dramatic pre-trends, whereas male caregivers, right, you see kind of very little change here, and this sort of very dramatic pre-trend, and that's pretty much the case, I'd say, for all of these outcomes. All right, so now these are just basic pre-post comparisons. So can we get some better identification here to try to identify maybe the effects of caregiving? Right, so there's likely a lot of confounding things going on here. Reverse causality, as I mentioned earlier, anticipatory effects, right? If you think you're going to start to need to provide care, maybe you're going to reduce your labor supply. Maybe you time your caregiving shock to a time where you know you are leaving your job. So in an ideal world, right, we'd be able to find a control group of people who are potential caregivers, right, which means they have the same ex-ante expectations about their caregiving role in the future, but they haven't started caregiving yet. And we're going to take advantage of the timing of shocks to try to construct such a control group. So we're going to compare caregivers in a treatment group to people who are going to start caregiving in the near future, which we're going to call the control group. So I'm going to call this a stack difference in differences approach. I didn't come up with this moniker, and so if folks have a more direction about what exactly this approach is called, I'm all ears. But somebody called it stack difference in differences once, and I thought that sounded good. So what are we going to do? For each calendar year, we're going to define a treatment group as those who started caregiving in that year. We're going to define a control group, right, as people who are going to start caregiving 6 years in the future. And for that control group, we're going to define a placebo caregiving shock that happens 6 years before their actual shock. And then we're going to redefine event time, right, for the control group, and we're going to center all the data around that new event time. Okay, so first I'm showing you just these same 6 outcomes I showed you earlier, looking just at raw comparisons, completely unadjusted between the treatment and the control group. The solid line here is the treatment group. The dashed line is the control group, right? And so the control group is untreated throughout this whole period, and they become treated in year 6, which is why we only observe 5 years of post outcomes. You can see, so for at least for the binary outcomes, the pre-trends here look pretty good. So our control group matches up with our treatment group pretty well, and we see these deviations start right around the time that the caregiving spell start. For earnings and self-employment earnings, these are a little bit messier, so we're working on cleaning these up a little bit. We see pretty solid kind of parallel trends going on in some of these outcomes. Okay, so then I'm going to repeat the event study, but now I'm going to have a control group to compare to. So I've got the innovation from the previous regression is that I'm adding an individual fixed effect, and then this treatment and event time interaction. Okay, so here's what that looks like. And again, as sort of was indicated by those by the raw outcomes, excuse me, we have pretty decent looking pre-trends, and then we see this discrete drop of about 2 percentage points. That's about 3% decrease in the likelihood of being employed. Earnings is still looking pretty messy here, but we don't see, I think importantly, we don't really see any changes in self-employment, likelihood of self-employment, unlike changes in overall employment, right? We don't see a lot of changes in claiming of disability, of retirement benefits, but we do see this discrete jump in the claiming of disability benefits right around the start of a caregiving spell. And this is about a 0.5 percentage point increase, and that is persistent over time, over the 6 years after the start of a care spell. All right, so I'm gonna, so these are just the pre-post estimates. I'll skip that and I'll conclude by saying that we see these immediate effects at the extensive margin, right? So right away we see decrease in labor supply, increase in disability claiming. These changes in employment reverse for some caregivers, but are permanent for other caregivers. So I'm thinking about that gender comparison. Now I didn't show you evidence from the survey data, but we're also able to repeat this whole analysis using the SIP survey data, which gives us a much richer set of outcomes to think about. Right? And we see that drop in employment in the administrative data corresponds to an increase both in unemployment and in non-participation. So we see people exiting the labor force, but also moving into unemployment. Right, and so what we're trying to do here really is highlight these dynamic relationships between caregiving and employment outcomes, which I think is really the first step, as I said in the introduction, in thinking about how do we want to design policies, right, and what kind of policies we want to have to maintain labor force attachment for caregivers, or maintain economic or financial well-being for caregivers. So I think in our approach where we're using self-identified or self-reported caregiving status, we're losing some of that strict causal interpretation, right? But we're gaining a bit in kind of thinking about these dynamic effects. And I think in the current situation with COVID-19 and the role, the emphasis on family caregiving, I think this is only going to become more important. All right, so thanks very much. And thanks in advance to Till for his comments.
Thank you. Now, Till van Wagner will discuss the last two papers.
Okay, I think you need to unshare.
Yes, I do. There we go.
Great, thanks. All right. Well, it's a great pleasure to be here. Thanks for having me. It's my second day of conference days that started with 7 a.m. sessions, so bear with me. But it's been a pleasure to read and to discuss these two papers. And it's actually quite fitting because both of these papers use event study methodologies to study the effect of a caregiving shock on caregivers' employment over the long term. And I've used that approach quite a bit when studying the effects of job loss. So I'll have some comments on that, as well as for both papers, some comments on how to relate yourself to the literature, because I think the papers have both a tremendous amount of data that they really haven't quite fully exploited yet. And that brings me to a general comment also for both papers, is that it's related to what Manasi was saying earlier. I've done a lot of work on UI, and there's a parallel here, namely that it's reflexive for labor economists to study the effect of events and insurance programs on employment, and often because that's what we really can observe well. But it turns out that some of the costs and a lot of the benefits of programs or the effects of the adverse events really go beyond employment. And so since you both have pretty tremendous data, I think it's worth thinking of whether it can help organize your thinking and exploit some of the data you have. Let me start with the impact of childhood health shocks on parental labor supply that uses Danish data. That's a very beautifully done, straightforward event study. And I'll be very brief in the summary. So the question here is, there's a range of shocks to child health that requires parental caregiving, and some of which trigger government assistance, but many serious shocks don't. And here they pick a specific condition, namely type 1 diabetes, as a sort of, they argue that is less related to lifestyle and genetic factors. And so it leads to sort of a clean event, and hence a clean event study. And that's when you do event studies, that's of course really helpful. And in fact, they then use parents of kids with the same exact date of birth and gender without type 1 diabetes as controls, and just use a standard event study approach and get a very nice set of outcomes that you saw, and the clear results. There are sort of persistent effects in earnings for mothers, mostly driven by part-time, and much less for dads, although there's a very short-term effects for dads, which certainly makes sense. I really like the paper. Very little to quibble. I have just a couple of general comments and a couple of possible suggestions. To me, I really like the proof of concept style analysis, but and I don't, I'm not very familiar with that sort of literature, but it struck me that there's a range of possible health shocks here. And you're right to be worried about selection and sort of average lifestyle. But I was wondering whether you could still exploit the dynamics around these onset of certain health events to look at effect of caregiving employment, in which case you could, use the fixed effects to get rid of, average employment differences and be able to study a broader set. And then, you have Danish register data. You could really go deep and exploit, and show the incidence of the effect of health shocks, the incidence of health shocks and their effect in the cross section, right? So I'd be very curious just to see your specific shocks effect and how it differs across the, say, income distribution, right? Both in terms of, you show the incidence, but in terms of the effect. And for other health shock, I'd be very interested in seeing how the incidence varies and the effects varies by socioeconomic status. So you may not want to do that, but to me, if there isn't a paper using register data to take stock on, how big of a role certain types of severe and semi-severe child health shocks are in determining, especially female labor supply, but also, father's labor supply and family income as a whole, right? Then, you probably certainly have the data to do that, to really clarify how important these shocks are in determining sort of life cycle employment in the population. Now, in terms of the event study, I do have sort of there's many ways to do this, but I think the following is a reasonably clear approach, namely you regress an outcome, say earnings, on a fixed effects, time effects, and then pre and post dummies relative to the event plus some controls. And you do something that's quite similar, but if you look at it in this way, you realize that if you need to exclude a pre-period to identify lifetime earnings difference, meaning to identify the fixed effects. And then the deltas capture the change in the outcome relative to that excluded benchmark period. Right? And then if you have a control group in there, which you do, the control group's change in earnings identifies the fixed effects, so that the coefficients delta becomes sort of a dynamic difference in difference interpretation, meaning that the change in earnings of the treated individuals before and after treatment relative to the benchmark period, relative to the regular change in earnings of the control group. And to me, thinking of this way helps really thinking through how specification choices and sample choices affect the outcome, because it seems straightforward, but there's a lot of things can go wrong under the hood, which I think in this case, that's not true, but there's one case where I think you might want to revisit what you do. And this is just a review. It's important to have a long enough pre-period that's included to properly identify the fixed effect. And then, you have an exhaustive set of post-event dummies. So the post-event is not determining the fixed effects, which you don't want. And then you can plot the dynamics before and after the event relative to the benchmark period. And that's really helpful for thinking through, pre-event dynamics. And I think you might want to try that out and see whether that works in thinking about your earnings estimate, because right now you have that year minus one as your excluded variable. And so it makes it kind of hard to think through these pre-event dynamics that are crucial in an event study, right? Because it's not experimental. You rely on your choice of exogenous event. And so having it set up this way helps. And I think, you start with this picture, which clearly shows sort of the data for treatment and control. And, that's a fantastic picture. And I would consider putting standard errors under two means. I personally also would always like to see just the raw treatment data, meaning, for different years, show me the pre and posts of the treatment groups. And in addition, what you can do here, this looks pretty phenomenal in terms of overlap, but your prediction regression showed that there is a difference in educational attainment other than immigrant status, and you could match on that to allow for differential trends by immigrants and differential trends for education groups. I think right now you just control, which takes away the means, but I don't think takes away the trends. But here's what I was worried about when I compare your fixed effect estimates. The first is the main figure, which shows just the difference between the two lines. And the second one is when you include fixed effects. The fixed effects figure seems to be shifted upwards. And I couldn't figure out whether you actually excluded some additional points. But if the only excluded point is -1, what the fixed effect does, it takes the average of the left figure and subtracts it, and so everything shifts up. And so by excluding a broader initial period, you're going to get those points in the fixed effect figure back towards the mean, right? And you don't subtract possibly the event outcome from your main estimates. Anyway, I really enjoyed reading the paper, very carefully and done. And I think I'm on time, so I'm going to switch to the second paper, which I also enjoyed reading. I could read event studies all day long, and it is really a great data set. So what the paper does, it takes, I think, a very underutilized data set in the US, which is the SIP match to SSA earnings records. And I am actually not sure whether it's now available through the Census Research Data Centers, but that's really an underutilized data source. And there is actually, John About did sort of a synthetic version of this. So if you're interested in this data, it's worth looking into it. And so that's the SIP survey, which is itself was a pretty rich survey matched to not only annual earnings data from W-2s, but also administrative SSA records on retirement and Social Security disability. And they exploit a caregiving module in the SIP to look at employment before and after the onset of caregiving. And of course, they also look at some of the administrative outcomes. And they have a nice way of summarizing their findings, essentially as sort of the average post effect on employment. Now, what I think, if I understand what they're doing right, and they do a very nice job explaining that the data is a key value added here, in the sense that most of what we know on caregiving from the HRS, which is representative of the population of workers age 50 and above. And here we have the chance to look at caregiving of younger workers, and the SIP also includes a somewhat broader range of types of caregiving. And so if I were, to think through, okay, how am I going to bench value added to the literature, I would probably put more emphasis on the ability to look at the incidence and effects of caregiving in the entire population, especially on younger workers, and think through how caregiving evolves over the life cycle and how it may have different effects over the life cycles. So, but to do that, I think it would have been helpful to me, at least, to take stock and more carefully lay out the underlying economic questions and some of the policy questions. And if you frame it that way, right, then I think it would be natural that we need to understand, right, how caregiving really varies over the life cycle and how the effects vary over the life cycle. And one way you could do that is to look at models of social insurance that are sort of have a much less complex decision problem relative to the life cycle labor supply literature, which would be, by the way, another great way to think through whether you could get a conceptual framework. But it may help you to think about the costs and benefits and have that as a framework to not only talk about employment and earnings, but also the additional outcomes you carry with you, namely, you know, ending up on Social Security disability insurance or filing for Social Security benefits. Right now, you have just a lot of different outcomes that you're just running through in terms of the descriptive analysis, and thinking through how to organize that would be really helpful. And it may be worth, you know, thinking through, you know, especially how this would fit in with our understanding or thinking about paid family leave. Now, just staying on that for a little bit, you know, you not only have a broader population, you also have, you know, quite some detail on the nature of caregiving, you know, where it happens, who receives it, how long it takes. And to me, it wouldn't only be very interesting to know how caregiving, how just the incidence of caregiving differs across in the population across age, but also especially by socioeconomic status. You know, this came up earlier in one of the presentations. I suspect there's a tremendous inequality in the effective economic burden of caregiving. And so if you stay in sort of the more strictly descriptive nature, right, one pretty straightforward extension would be to sort of zoom in on that and say, okay, can you quantify, you know, what is the economic cost of caregiving across the income distribution? I think that would be a very important paper, really exploiting the data you have. I have some specific comments. One question that is coming up throughout the paper is this question of dynamics, because as you saw, there's pretty strong trends in employment of caregivers. And you have, I wonder whether some of the detail on the type of caregiving can help you better understand the dynamics, and perhaps some of the cross-sectional differences that you find in the dynamics. So does caregiving differ for older and for younger individuals? It would also be worth considering whether you can sort of take a cue from the paper on Denmark. Whether is there sort of a proof of concept type caregiving shock that seems to be more exogenous than others, to help you with identification a little bit, and also think about this issue of pre-trans. Yeah, I was confused a little bit, and I'll come back to that on the question of pre-trans here. There are strong trends in employment, but that's not necessarily a problem for the event study if you have a control group, and you show that, you know, the control group works reasonably well, and I'll come back to that. Given that you have such a wide range of types of workers and of events in the sample, I wonder whether it makes sense to consider a matching estimator, meaning that you, before doing the event study, do match pre-development, at least for employment and earnings, looks quite good. But yeah, I'd be worried that there are not very different potential underlying group-specific trends that you could reasonably easily control for, right? The alternative would be to put in time trends interacted with the group indicators. I would highly encourage you, just as a practical suggestion, to, you know, implement the event study as you're doing it, or, you know, possibly the, you know, a more simplified version with a benchmark period that's excluded, so you don't have to worry about identification of the fixed effect, and then show the entire path of pre and post coefficients. Right now, you show the raw data, and then you jump to looking only at the post outcomes. But I personally would really like to look at the pre, the evolution of the outcome just before the event, because that will help you also to think through whether, you know, the control group you're picking is the right control group, because that's a bit of a concern, given that the control group will eventually be treated, right? If there are sort of pre-treatment dynamics, those will affect your control groups down the line, which affects, you know, your main estimates. Now that, you know, Julia was really helpful in sort of answering my question via email. Now that I understand why you were using a model based only on the treatment group, or I'm not sure that I find that informative. So let me, if I have a couple more minutes, I think. You know, this is the same slide that we saw before of sort of, you know, one way to think about event studies.
You have about 1 minute till.
Okay, here's the slide. But if you would not have a control group and just do the same thing just based on the treatment group, and it doesn't matter, you know, you can, well, then without a time trend, the dummies just measure the difference relative to the mean of the individual, if you want, because you have a time series and you have sort of an excluded period. Once you include the time trend, you really need a pretty long pre-period to identify the time trend based on pre-period information. And now you do have very long time series. You probably have even more data than you showed in the pictures. So you could do that, but if you do that, then you have a pretty strong assumption, namely that the time trend is fixed over pretty long stretches of the life cycle. And, you know, if you look at life cycle trends in earnings and labor supply, that's going to be a tough assumption to maintain if you want to allow enough of a pre-period to actually fully identify the linear trend. So I think you don't need to do that, given that the control group seems to work quite well. But if you do that, you know, I would revisit how you set the problem up. And I'm going to stop here. And again, it was a pleasure to read those two papers, and I look forward to seeing the revisions.
Thank you. We now have some time for questions from the attendees, I think is the correct terminology. But there's one here that I think we can all see. I think this was actually with respect to the last paper, but Chris McLaren asked, can you discuss why there's maybe an increase in disability insurance receipt for caregivers? But I think this actually has some applicability across the paper. So the authors may want to also comment on that.
Yeah, thank you. Thank you for the question. So this is something that Priyanka and I have talked quite a bit about actually offline, but I suspect that DEI acts as some sort of income support for, so I think about these social insurance programs like paid leave, like UI as providing income support for caregivers. So I saw Manasi had a paper that was presented yesterday where they look at, like again, in this general literature of these other effects of these programs beyond what is actually targeted. So DI provides some income support. We know that a lot of people on DI have some caregiving capacity, right? They may not have earnings capacity, but and I'm not very familiar with this literature, so I'm happy to hand this off to Priyanka, who knows it more, but you know, have some caregiving capacity. And so there's some complementarity there where if you're you know, if you're not able to work, you can take care of somebody and use that DI as kind of an income support.
Priyanka, do you want to comment on this?
Oh, no, I mean, I agree with Julia. The thinking there was that, once you are receiving this DI support and you do have some earnings potential, you may be using that time to provide caregiving. So I agree with what Julia said. And I think this is an area that Julia and I are actually hoping to look into more, trying to explore, to what extent are people who are receiving DI using this time to provide caregiving. So we were actually excited to get that question because it's something we've been thinking about.
From the attendees, if there are any other questions, please do type them in, and if not, I'll come back if we get some questions. But would any of the paper presenters like to respond to any of the comments made by the two discussants?
I'll just say thank you, Manasi. Those are really thoughtful comments. I really appreciate you putting it in the broader context of thinking about this sort of unintended effects, or maybe that's not quite the right way to say it, but the broader effects of these programs. I thought you had some really good suggestions about thinking more carefully about family composition. So right now we're controlling for household size, but not this, kind of 2-parent versus 1-parent household issue. And we do have information about that, as well as the age of children. So those are definitely like very helpful suggestions we can implement right away. And yeah, some of those.
Stephanie, can I ask? So if you're controlling for household size, what is where is the variation coming from? Because my impression from the paper was that your variation is coming from household size, but
right.
I wasn't
so
sure
we're not controlling for it within state. We're controlling for it like kind of across states. Yeah. But we should push more on that. It's a good thought to like really think more carefully about where those sources of variation are coming from. So yeah, very helpful suggestion. So thank you.
Yeah, I can also piggyback on that. Thank you, Manasi, for your comments. They're super helpful. And I was actually really happy to hear both Till and Manasi emphasize this need for getting a bigger picture of what's going on beyond just the employment effects. And it's something that we definitely would like to look into using the SIP, because the SIP does have a lot of really helpful information about the family as a whole beyond just employment. I also appreciated the suggestion to look at the response of the spouse themselves, their labor supply decisions around the disability. We've talked about that. The one tricky thing about that is that we do define disability as having a work limiting disability. So we know by definition, we're going to see this drop in their labor supply at the time of the shock, except for that third definition we use, which is disability of any type. So we are going to see that definitely, but I think that your point is well taken, that it would be interesting to look at, is that sustained over time and kind of patterns of employment of the spouse themselves, even though we know by definition there's going to be immediate drop, especially when we look at those illnesses versus the chronic conditions. It could be interesting to look at those patterns. So thank you for the suggestion.
Yeah, got it. That makes sense. So the work limiting disability, that's a separate question, right? Than actually looking at their hours.
It is. So we actually combine the two. So we look at people who say they either have a work limiting disability as that separate question. And then we look at the people who say that they're not working. And the reason for not working is because they have a disability. So you're right that potentially that first group, they could have some employment. So maybe that would be a reason to separate them out and kind of look at different patterns. But you're giving good food for thought that that's something we should include and think about how to work it in with our current analysis. So.
Great.
Amanda, there's a question for you, which was if you could talk about from the attendees, the genesis of the use of type 1 diabetes as this exogenous disability shock, and the kind of follow-up was whether you considered any other kinds of specific health conditions. So if you can wrap that into any comments you'd like to make in response to those comments.
I should say, I appreciate Till's comments of thinking about more broadly, because we have been very focused on type 1 diabetes. Jannet is a pediatric endocrinologist. And so we've really been thinking about it that way, but it is, now that you say that, I feel like it's opened up all these other possibilities to think about these other types of chronic conditions or disabilities. So, I mean, part of it is this is something that we were more familiar with and thinking that it might be, you know, more plausibly exogenous. I'm not sure how easy it would be to get other potentially clinical data, although I do believe we have hospitalization records, so we may be able to get some others. I would have to discuss with my Danish co-authors exactly what limitations are in terms of health records that we have access to. I mean, part of it is that Jannet is in charge of the diabetes data, and so then we have data for all of that types of all of those sorts of medical records. So I guess it would just be figuring out what other medical data we could actually get access to through Statistics Denmark. And I also appreciate your comments about perhaps just matching on immigration and academic background would be easier. We've been trying to think of different ways to like address that, and we kept thinking, well, this is going to seem suspicious if we do this, but that would make a lot more sense and not probably cause the problems that we were coming up with that could happen with our other ideas that we were trying to come up with.
I mean, if you only have one or two groups you're worried about, just including an interacted time trend would be very similar to matching, and without all the overhead of having to, you know, run the propensity score model and do balancedness and so on. So you could just try that.
Thank you. Yeah, we, like I said, we've kind of banging our head against the wall with that. So that would, yeah, definitely solve that.
Julia, did you want to comment at all or respond to any of Till's comments? You kind of have.
Just to say thank you. That's great perspective. I appreciate the comment to get some sort of framing theory. I think often a lot of the struggle I've had with this paper is just kind of like throwing spaghetti at the wall to sort of, you know, what do I think might happen, but certainly, you know, structuring it in a framework would be informative, and I think it would also probably make the paper much more readable in terms of what's going on. And then the other thing that I struggle with a lot is the econometrics and what exactly those event studies are telling me and how to think about those pre-trends. So I appreciate those comments as well. I'm gonna have to look at your slides again and maybe watch the recording of this one more time. But yeah, no, that's super helpful. Yeah, I think it's gonna push me past a point where I'm stuck.
Any other comments? They threatened that the statement is that in I think 3 minutes they're going to shut this thing off. So if there are parting comments in the 3 minutes we have left, feel free.
I'll just say I was excited to see two papers looking at kind of disability and caregiving using the SIP, because I've often been not sure if it's really feasible to implement these types of studies on this population with the SIP. So it's great to see, you know, that you guys have kind of gone for it, and yeah, that it seems to be viable. So that's really exciting.
And Julia, are you accessing the data through a co-author at SSA?
Yes. So it's my first time doing that, and it's incredibly helpful. But it's also my first time where I'm not able to touch the data myself, and it can be frustrating for everybody involved sometimes.
It used to be that at the Cornell RDC, they were hosting the synthetic SIP.
Yeah, so
I mean, at least it's for debugging and stuff.
Yeah. The synthetic, yeah, and actually the synthetic SIP would work. And we have an RDC, there's an RDC at the University of Michigan, so in principle that's accessible. It's kind of it worked out very well because it's kind of a moot point this year anyways. Nobody can go into an RDC, so, you know, that would have been completely shut down if we didn't have the co-author, but yeah.
One of the things we all should do is encourage the Census Bureau to continue the use of virtual RDCs, which for a period of time the pandemic required. And you know, I think they haven't made a final decision, but there's talk of them sort of essentially backing away from that. And I think it's for broad user communities would be a real loss. It's kind of like reading these articles about, are we going to return to our offices when the quote pandemic is over? And a lot of things have changed. We've got 1 minute left, or now less than it. So I would like to thank all of the authors and all of the two discussants and all those who participated. At one point, we had about 36 people listening to this session. So thank you all for a really good and interesting session, and look forward to reading the papers. Thank you.
Thanks. It's
Thank
great
you.
to see everybody.